Prof. Thank you, everybody else, for still staying in front of the computer or handphone to continue with my presentation. Okay, I will present 3 cases, short case studies, so it won't take too long. Okay. All right, first case, 66 years old Chinese lady complained of altered bowel habit for investigation, but incidentally, she has breast lump. Ultrasound was found there are multiple cystic lesion with BRATS 4. So FNA was done, proceed with true cut biopsy. So this is the BRATS category by radiology. So it's include 0 to 6 category, but for this case, it was categorized as 4. So it is quite highly suspicious for diagnosis. So they suggest either tissue or FNA. So clinician decide to proceed with FNA first before to proceed with tissue biopsy. So this is the low power view of the smears from the breast lump. Okay, so if you can see here, this is an adipose tissue, and this is all the ductal cells. It looks benign, looks organized. Okay, some of the area shows like papillary-like structures, but not too prominent. Okay, and this stars is actually the crystals artifact, mounting artifact. Okay, on higher magnification, if you can see this, the clusters, they are cohesive, very organized. However, if you can appreciate, it shows apocrine features. Okay, I'll show you in a high power view. So at the same time, you might appreciate the papillary structures here and there. Okay, it looks like the end of the like a finger-like projections, 3D arrangement, cellular arrangement at the end of the finger projection. Okay, this is on higher magnification. So this is from the previous one. Okay, the cells, the apocrine cells, it looks organized with round nuclei. However, there are some cells a little bit look larger, okay, larger with prominent nuclei, but still looks, it doesn't look like malignant lah. And if you can appreciate, there are myoepithelial cells, okay, the smaller cells here and there, the darker cells within the cell clusters, okay, and here are forming histiocytes. So there is evidence of cystic changes. That's why in ultrasound, it shows cystic features. Okay, in other areas, this looks like a normal benign ductal cells. Okay, it looks organized. Some are monolayered with presence of myoepithelial cells. Okay, this is the pap stain. This is also apocrine cells arranged in one single layer, very organized. Looks so benign looking, but there are still some cells look larger. Okay, this one, benign ductal cells. So there are 2 populations of cells here. One is normal benign ductal cells, looks like a fibroadenoma. But the other one, which is more prominent in the smears actually, majority of the cells are apocrine cells. So because of that, okay, the reporting pathologists decide on report it as atypical because the smears is cellular, number one. There are apocrine, majority there are apocrine cells, as well as some nuclear atypia. Right? So there are challenges to diagnose apocrine lesion in smears. So it might include apocrine adenosis or metaplasia, and also atypical apocrine lesion like apocrine ductal carcinoma in situ, invasive carcinoma with apocrine change or apocrine carcinoma. So the reporting pathologist end up give the interpretation as atypia with apocrine changes. So after that, the surgeon proceed with, the patient went to private because maybe she wants to get a earlier management. So she went to private hospital and they did an excision biopsy of the lump, and from that it was reported as papillary lesion with apocrine changes. Then they referred the tissue block to us with the patient. Okay, so this is how the HPE looks like. Okay, from the low power view, as you can see here, there is a cystic spaces. Okay, and within the cystic spaces, there are papillary structures, complex papillary structures, arborizing structures, papillary structures lined by majority by apocrine cells. Okay. At the edge of the lesion, there are aggregates of histiocyte, hemoglobin laden, foamy histiocyte, cholesterol cleft, and this is the lesion with apocrine changes. Okay, this is the center of the lesion, apocrine metaplasia, if you can appreciate here. And this area looks like benign papilloma-like lesion, higher magnification. Okay, this is non-apocrine, and this one is the apocrine changes. It looks larger, it looks very florid. So sometimes the pathology is having a difficulty to even diagnose papillary structures with apocrine changes. So she proceed with P63 and CK56 stain, and it turns out that they are positive even within the center of the lesion. So meaning that the myoepithelial cells present throughout the papillary lesion. So the diagnosis, of course, is an intraductal papilloma with apocrine metaplasia. And surprisingly, apocrine metaplasia is so florid in this case. Okay, I look up for some journal. Apocrine papillary lesion is clinical pathological difficult to diagnose as benign or malignant. Benign papillary lesion are classified as intraductal or intracystic papilloma or papillomatosis, while malignant papillary lesion may include papilloma with DCIS or papillary DCIS or encapsulated papillary carcinoma, solid papillary carcinoma, and invasive papillary carcinoma. So the myoepithelial cell layer may disappear even in obviously benign apocrine metaplasia. So therefore, the presence or absence of myoepithelial cell layer is not useful for differentiation between benign and malignant lesion. So in this, I can't show in the slides just now that there are some clusters, smaller clusters of apocrine cells without myoepithelial cell present. So sometimes it's quite difficult to say whether this is malignant or not. Benign breast lesion, okay, apocrine cells when degenerated will most often appear atypical, especially if it has progressed over time to the phase of chromatin clumping with associated anisoneucleosis, and this could potentially be labeled as suspicious. So like this case, there are some nuclear enlargement and pleomorphism in the apocrine cells. Benign breast lesion are usually easy to diagnose. when their characteristic cytologic patterns are obvious: hypocellularity, degenerated apocrine cells, necrosis, and epithelial hyperplasia are some the factors that may be accounted in evaluating difficult smears. So mimic atypical or malignant lesion. Overlap of cytologic features in non-neoplastic and neoplastic benign papillary region and between benign and malignant papillary neoplasm necessitates histologic evaluation in all cases diagnosis as papillary on cytology, since 49.2% of lesion showing papillary features on cytology proved to be malignant. So once papillary, clear-cut papillary in cyto, you have to proceed with excision or true cut biopsy, or better is excision. All cases reported as papillary on cytology should be excised urgently for histology assessment. Okay, next case, 35 years old, Malay lady, June 2018. She noted a breast lump, left breast lump, slowly increasing in size, 2 cm in diameter. Ultrasound, suggestive features of fibroadenoma. Then FNA was done in August, 2 months later, suggestive of benign proliferative breast lesion with atypical cell seen. Then later, based on this finding, excision biopsy was done 1 year later. Okay. Most likely patient defaulted, and then because of the lesion getting larger, then she went back to the hospital for further management. So this is the smears. It's low to moderate. Some we can see here there are aggregates of cells. It doesn't look like typical ductal cells. Okay, these aggregates. This is maybe ductal cells, we don't know, but there are a lot of single cells. It looks like a bare nuclei, but some are larger than the others. Okay. On higher magnification, okay, this is another aggregates of probably ductal cells or probably not, but it doesn't look like typical ductal cells. Usually we can see myoepithelial and usually it organized, but this one is not. If you can see the background cells here, there are quite significant numbers of larger cells. It doesn't look like lymphocytes because it's larger. Okay, this is maybe lymphocyte, but this one is not. Okay, this one may be something. Okay, maybe lymphoid globules. Okay, this is the pap stain smears slides. Okay, also shows some singly dispersed cells without cytoplasm. It looks like a band nuclei, but it larger. Okay, they are larger than usual. Higher magnification. So this is obvious. It looks very atypical, but there are no cytoplasm attached to the atypical nuclei. So it looks larger with open chromatin maybe. So this is maybe the ductal cells, we don't know. This is on pap stains. Also we can see larger bare nuclei without cytoplasm. So based on this, okay, because of that, it was reported as atypical, suspicious, but we don't have a cell block, okay, to proceed with immuno. So at that point of time, the reporting pathologist decide to put it as atypical, it's suspicious, but they don't, at that point of time, they don't dare to put it, it is a lymphoma. So the surgeon proceed with excision of the breast lump. So it turns out that there are diffuse infiltration by malignant lymphoid cells. Okay, malignant lymphoid cells, which are larger cells with scanty cytoplasm, and some cells have multiple prominent nuclei. If you can appreciate, apoptosis is obvious. Maybe this one is mitosis. And it turns out that LCA, CD20, CD10 are positive. There are a long list of immuno was done, and it turns out to be a diffuse large B-cell lymphoma, germinal B-cell subtype. So patient was follow up. Now she has completed 6 cycle chemotherapy, and she was under close follow-up under hematology. On CT scan, there is no hepatosplenomegaly and no lymphadenopathy. So it seems that this lymphoma is primary from the breast. So lymphoma from the breast may be primary or secondary. Most common type include diffuse large B-cell lymphoma, like this case. Others includes extranodal marginal B-cell lymphoma, mild lymphoma, or follicular lymphoma and Burkitt's. So primary breast lymphoma is uncommon. So must be distinguished from secondary breast involvement from another primary site in the setting of widespread disease or relapse. Diffuse large B-cell lymphoma must be distinguished from poorly differentiated carcinomas. Okay, this is the dilemma when the reporting pathologist while diagnosing the smears. Differential diagnosis includes, it can be lobular carcinoma. So if it is lobular, so some features like intracytoplasmic lumina, signet ring cells, or intracytoplasmic mucin should be identified. Small cell carcinoma, okay, cell clustering, cell molding, lack of lymphoglandular bodies, and positivity to CK and neuroendocrine markers. Okay, others differentials, high-grade carcinomas with medullary features. This is usually polymorphous appearance. Usually the background are more like reactive lymphoid cells rather than atypical cells. Intramammary lymph nodes, okay, maybe the surgeon did the FNA at the lymph nodes, we don't know, can. So all of this must be in our head, before we pen down the diagnosis during cytology. Okay, last case, 44 years old Siamese lady, presented in 2019, right breast lump, mammogram was done, suspicious oval-shaped lump, BRATS 4B. So the history written in the pipette form was short and sweet. So this is the one. Then based on this, okay, FNA was done in January last year and followed by biopsy and white excision. Okay, this is the smears. It is more like low to moderate, but more towards lowish side. There are clusters of cells here, but it doesn't look like typical ductal or fibroadenoma-like presentation. So on higher magnification here, if you can see, there are prominent capillaries here and there with intermingled small cells surrounding the vessels. Okay, on higher magnification, it looks like granulation tissue, right? I mean, with this ever-rising capillary structures, with surrounding cellular stroma-like cells. Can't see any typical ductal cells. So this one, it doesn't look like a typical breast or primary breast lesion like fibroadenoma or malignant carcinoma. So Okay, this is another higher magnification. A lot of capillary structures here and there. Maybe there are few ductal cells, and this may be the bare nuclei. Okay, we don't know. This another clusters also shows prominent vessels here and there. This is the peptine. Looks like adipose tissue, or maybe the granulation-like tissue, but the thing is there is no inflammatory cells in the background. So based on this, with very short history given in the pipette form, so the reporting pathologist decide to put it as atypia, undetermined origin, or undetermined behavior. It's not behavior, undetermined. Okay, I can't remember the words. Okay, so this is the biopsy. All right. First, they did the true cut biopsy, and the biopsies confirm this, and after that, followed by wide excision of the lesion. So, because of the HPE looked like this, then we tried to investigate further and found out that the patient actually had history of renal cell carcinoma, and nephrectomy was done in 2009, so about 10 years back. Okay, so it was in the system but not written in the request form. So based on that, then we proceed with RCC immunostain. It turns out to be positive. Based also on the morphology, clusters of cells, clear cells with centrally located nuclei with mild to moderate nuclear enlargement. So definitely this is the RCC, metastatic RCC. So history of right RCC nephrectomy in 2009 was only found out during diagnosis of a tissue biopsy. Okay, a little bit about RCC metastasis in the breast. Renal cell carcinoma is a malignant tumor that often metastasizes early, and approximately 33% of RCC patients present with metastasis. So commonly metastasized to the lung, skeleton, lymph node, liver, adrenals, and brains. Others are uncommon, which is include breast. Breast, okay lah, very extremely rare. Therefore, a history of RCC arouses suspicion of concerning breast metastasis, even though primary carcinoma of the breast is much more common. The prognosis for patient presenting with metastatic RCC was bad, and the median survival time was only 6 to 12 months, and 2-year survival rate was 10 to 20%. Surgery played an important role in the management of patient with metastatic RCC. So I retrieved back some cases published in the literature regarding metastatic RCC to the breast. There are actually not really rare. Even after 2014, I think there are papers in 2018, 2019, and even 2020. There are also reported cases metastatic RCC to the breast, so, which is include this one. Okay, the differential diagnosis offered were primary breast carcinoma with possibly of metaplastic carcinoma and metastatic carcinoma. Cytomorphological features of FNA in case of RCC might not always be characteristic. So therefore, cytopathologists should be familiar with the various features associated with subtypes of RCC. So this is very difficult. Fine needle aspiration showed atypical cells arranged in cohesive clusters with focal papillary architecture entangled in eosinophilic stroma and cellular stromal fragments, which I showed you in my case. So the cells were small with ill-defined cell border, granular to focal vacuolated cytoplasm. So in our case here, I don't see any vacuolated cells. Mild anisocytosis and indistinct nucleoli. Stain for mucin was negative. Then further histological correlation and ancillary studies including immunos should be done. So to remember, the triple assessment for a lump in the breast is a standard practice toward diagnosis of breast cancer. The combination modalities include physical examination, imaging, and FNA is more accurate than any modality alone. Triple assessment is considered positive when one of the three modalities among clinical examination of breast imaging and histology is positive and is deemed negative when all three modalities are negative. Okay. So lastly, the combination of all the modalities gave a positive predictive value of 100% compared with the surgical pathological diagnosis. Correlation with previous history of known cancer is important. It is advised to perform cell block for each case of breast FNA to decrease the pitfalls and to improve the diagnosis and management of the breast lump. So sometimes in the cell block, we can't see microbiopsy tissue. And further immunohistochemical study can be done. Just remember, FNA cytology, there are limitations in diagnosis of the breast lesion. So they are include atypical ductal hyperplasia, in situ lesion, papillary lesion, apocrine lesion, or even metastatic lesion. So these are the references. Okay, thank you.